Good morning, everybody. This is Brittany with the Seniors Blue Book, and this morning I am joined by Coastal Orthopedics physician, Dr. Bundschu. Good morning.
Good morning.
How are you today?
I'm doing good.
Good. You look great. I'm excited to learn more about spine and pain and just kind of how to manage and care for those. Thank you for your time today.
My pleasure.
So tell us a little bit, for those that don't know you or much about Coastal, tell us a little bit about your background as well as some of the different kind of services that Coastal provides.
Okay. Well, first I need to explain a little background behind the field because the field of pain management is relatively new. The first board exam in the field of chronic pain management was 1993, which is not that long ago. I've been practicing since 1996, which classifies me as a dinosaur. But I've been with Coastal here for about 15 years. There's a lot of misunderstandings and misperceptions in the community as to what pain management is and what it isn't. Because we live here in Florida, and there have been more than our fair share of pill mills, primarily in Dade County, Broward County, which is Fort Lauderdale, Miami, it's given us all a black eye. But the good news is we've pretty much gotten rid of most, if not all of those. And now it's a more well-respected field and more scientifically based. And that's what's important to understand, because when you're having pain, for instance, if you're burning your finger on the stove or you cut yourself in the kitchen, that's a useful pain. The signal of pain goes up to the spinal cord, goes to the brain, says, ouch, you pull away. That's a useful pain. The problem with chronic pain is your brain is tired of hearing it. There's nothing you can pull away. So for chronic conditions, arthritis, herniated discs, severe chronic muscle strains and sprains, they hurt. No doubt about it, they hurt. The question is, for us, for every patient that we evaluate, we need to elucidate and scientifically determine what % of their pain is coming from a pinched nerve or a muscle or a joint. Until we find a cure for arthritis, that's a very common piece of the puzzle, if you want to look at it that way. One thing that we have here at Coastal, which makes us very scientific, we have an MRI machine, we've got physical therapy, we've got everything that we can offer the patients with common causes of chronic pain, the treatment, and successful at that. We have surgeons who are minimally invasive. They've trained at Stanford, Northwestern, etc. We have all of our physicians are board certified and fellowship trained. Most of us are nationally known, and we've got excellent reputation. So if someone comes in with chronic back pain, that's a very, very common scenario. We do a head to toe neurological exam. We do a motor exam, a sensory exam, a reflex exam, and then when indicated, we'll get some imaging studies that are very important, such as MRIs or CT scans. Sometimes we have to get other imaging studies. Sometimes we have to order an EMG to see if there's any evidence of chronic nerve damage. These are all tools we have in our toolbox to help understand the etiology and what's causing that person's pain. Once we get that data, then we meet the patient in the office. We go over everything in person. If appropriate, especially now with the COVID pandemic, sometimes we have to do it over the phone, but we like to have a visual so that way we can show the MRI or CT scan on the computer screen so the patient understands what is causing their pain. And that's when we come up with a plan to basically maximize our chances to improve the patient's pain, to improve their quality of life, decrease the pain medicine they're taking, get them on an independent program so they can stay away from doctors like us, and to help educate them as to what they can do to play their part in the treatment plan.
So Dr. Bundschu, I know a lot of the clientele that we serve, seniors and the aging population, they deal with chronic pain. And that chronic pain can be so debilitating. Can you talk to us a little bit about chronic pain and how you do some of the treatment there or some of the options that you offer through Coastal?
Okay. Let me go over a very common scenario. Someone comes into our office. They've had chronic pain for 6 months or 6 years or longer. They may have undergone 1 or more back operations, and they're still in chronic pain. What do you do with these people? So, like I said earlier, we get the proper imaging studies, the proper tests to find out what's causing the pain at this point in time. Very commonly, when someone has pain that goes from the back down the leg or from the neck down the arm, many times that's because they have a pinched nerve. The issue is what's causing it. Commonly, herniated discs, stenosis, which means basically the arthritis is causing the spinal canal to be decreased in diameter. Sometimes we see tumors. Maybe someone had a previous history of prostate cancer or breast cancer that metastasizes to the spine. That's not uncommon. Sometimes people have just bad arthritis. Sometimes people have other conditions that can cause radiating pain. So that's a very common scenario. Also, a very common scenario we see is people who have chronic neck pain after a car accident or after falling down a ladder or something traumatic. Someone who's trying to saw off a palm front, very common scenario here in Florida, especially after a hurricane, and they fall off a couple steps. That causes a lot of head and neck pain. When people have neck pain that radiates to the back of their head, what chiropractors and lawyers will call whiplash, we call cervicogenic headaches. And unlike migraines, they have a whole different treatment treatment option list that does not involve Imitrex or Zomig or Emerge, which are very good medicines for migraines that are vascular in nature. But we see a lot of patients with pinched nerves because of arthritis or trauma. Likewise, someone may have pain in their back only when they golf or when they play tennis, and it does not go down the legs. Often that's a sign of facet arthritis, which are the little joints that connect the vertebrae together. And we have some very high-tech options called radiofrequency, where we can, under X-ray guidance, place a probe that looks like a needle. We do this under sedation if necessary, so the patient's not worried about that. And usually we can decrease that person's pain minimum 50%, minimum 6 months or longer. Sometimes it lasts for years. I've had several patients where you do a radiofrequency and their pain doesn't come back for 6-7 years later. So it's very, very useful. Other chronic conditions we see, someone who had shingles, they get the rash improves, they still have pain. We commonly will do epidurals or other things for those. Sometimes we do medication management, but that is not the norm. Usually if someone has an illness that is terminal, we want to make this for people comfortable as much as we can. Sometimes that includes narcotics, opiates, the things you always hear about on TV that are addictive. But I find most people, unless they have an addictive personality, they don't get addicted. The majority of patients I see, you tell them to take a medication on a certain pattern per hour, they follow those directions. However, one of the things we as professionals have to be alert to are signs and symptoms of misuse of pain medicines. And people can fall in that trap very easily. So it is our part of our responsibility to make sure that they don't fall off the wagon. They take their medicines appropriately. Sometimes we have to test their urine to make sure that A, they're taking what we give them, and B, they're not taking something that we're not giving them. And unfortunately, that's just part of the job and nature of the beast. But we also are really into self-stretching, aquatic therapy, yoga, Pilates, core stabilization. These are things that the patient can do on their own that really helps them with the chronic pain treatment plan.
And what about with the spine? So what are some of the maybe more common procedures that you do at your office there?
Okay, well, we usually give the patients two choices if we're going to do a procedure. For those patients who are like this in the dental chair, we tend to sedate them. Most patients don't require sedation. We usually will use numbing medicine, local anesthetic at the skin level, and we very commonly do epidurals. Now, there brings up another issue, because most people, when they think of epidurals, they think of pregnant women. And that's true. Epidurals are very useful for surgery, C-sections, delivery of babies, etc. But the type of epidurals we do for pain is a little bit different. We typically put a very small amount of anti-inflammatory in the epidural space, which is not in the spine, but in the space that surrounds the spine like a moat surrounding a castle. We do it all the time. It's very safe, very easy. We do every precaution to make sure no side effects occur. If someone's on a blood thinner, we coordinate with their family doctor and their cardiologist to make sure it's safe to stop the blood thinner before we do such procedures. We get medical clearances all the time, and it's a very common thing. That's probably the most common thing we do, are epidural injections. And again, we put a very small amount, 1/10 of a teaspoon 1 cc, if you will, of anti-inflammatory only where it needs to go. Whereas if someone takes a pill, it goes through the mouth, through the stomach, through the blood, through the liver. Not much of that pill gets to the actual source. And that's why they have an advantage by using very tiny needles under X-ray guidance, or what we call fluoroscopic guidance. And that way we can assure the medicine goes exactly where it's necessary and not where it's not needed. So now those are usually the most common things we do. I alluded a little bit earlier about some of the high-tech options like radiofrequency. We have all sorts of options. We have kyphoplasty, which is where you, for compression fractures. That's a very common thing with our older population. Someone may cough or sneeze or fall down, and one of the vertebrae has a fracture. The vertebra, when they fracture, it's not like an arm fracture or a leg fracture. It's more like squishing on a Coke can, if you will. So we will, again, we under X-ray guidance, we put bone cement in there and we inflate a balloon, and that's very useful for that treatment algorithm. When the minimally invasive things fail, we have some more high-tech options. We have spinal cord stimulation, which is a very, very advanced option. We typically use it less than 1% of the time. But for those patients who've had numerous back surgeries, they failed epidurals, they failed physical therapy, they failed medication management, it's a great option. It's a 2-step process. We put in 2 electrodes percutaneously, which means they're through the skin. Of course, we sedate people for that. They've got 6 days to do the test drive. Most people come back and go, wow, this is amazing. Nothing else has worked. And we've been very fortunate because we have a research division, and we've been published numerous times over spinal cord stimulation, both in the lumbar and the cervical. I'm very proud to say that the study we published in the Journal of Neurosurgery this past December of the cervical spine was the first of its kind. So we were very proud to participate in that study. And the results were very impressive. So we like to be very scientifically based here at Coastal, and we like to, we pride ourselves on doing what is needed and necessary to help the patient regain their life back.
So each person that comes into you has their own story. They have their own set of chronic pain, and not everything works for each person the same way. So what are some other alternatives to what you've mentioned so far?
Well, like you mentioned, everyone's different, thank goodness. And everyone has a different history of what's tried and what hasn't tried. So that's part of the initial intake, is to find out exactly what's been done. If they have had surgery, we like to look at the procedure notes to confirm exactly what was done. Imaging studies we talked about. Anyway, for patients who have surgically correctable lesions, i.e. they've got really bad stenosis and they need what's called a decompressible laminotomy, we have those options here at Coastal. We've got 2 very excellently trained spine surgeons that have been with us for years, and they're minimally invasive, and they're very conservative, and they do a great job. And so the issue is, whatever the patient needs, we can come together with a treatment option that's tailor-made for that patient's individual situation.
I really appreciate all of your information and education you're providing. I know the people that tune in it's a mix. It's, you know, it's seniors, it's their family members or caregivers, as well as professionals. So I would love for them to be able to refer their loved one, themselves, or their clients to you. So I'll make sure I post everything, of course, with your educational video here. Any last words of advice that you'd like to offer to people that are watching?
The best way to stay away from people like us is to stretch every day, laugh a lot, and try not to watch the news.
I like that. I'm doing most of those. Maybe just stretching I need to add.
And breathe while you stretch, very common.
Well, thank you so much, Dr. Bundschu. I again truly appreciate your time, and I know it's very important. So everybody, please reach out to Coastal Orthopedics. They're amazing. And thanks for tuning into this video, and have a wonderful day.
Thank you.